Emily Davis is an 18-year-old female presenting with localized non-bullous impetigo characterized by multiple honey-colored and crusted lesions on face and arm without systemic symptoms. According to current Infectious Disease Society of America (IDSA) recommendation and evidence-based dermatology guidelines, topical antibiotics are the preferred first-line treatment for localized impetigo because they are highly effective while minimizing systemic antibiotic exposure. The first-line medication one is selected is mopirocin 2%. If Emily lesion becomes extensive, fall typically therapy or involve numerous body areas, systemic antibiotic therapy would become appropriate. My second-line treatment would be oral cephaloxime, known as Keflex, a first-generation cephalosporin. Cephaloxime inhibits bacterial cell wall synthesis by binding to penicillin binding proteins, resulting in bacterial cell death. It is highly effective against methicillin sensitivity, Staphylococcus aureus, and Staphylococcus virogens, making it an excellent choice for uncomplicated widespread impetigo. Pharmacokinetically, cephaloxime is rapidly absorbed after oral administration, which is peak plasma concentration within approximately 1 hour, has a life of about 1 hour, and is primarily excreted on the chain by the kidneys. Dosage adjustment may be necessary in patients with renal impairment. My prescription for Emily would be mopirocin 2% ointment. Apply a thin layer to affected area or lesions 3 times daily for 5 days after washing the lesion gently with soap and water. Dispense 122-gram tube with no refills. Emily should return within 5 to 7 days for reassessment. If lesions worsen, continue spreading, or systemic symptoms such as fever develops, reevaluation for oral antibiotics is indicated. Because mupirocin is minimally absorbed, clinical significant drug interactions are common. The most frequently reported adverse effects include localized burning, itching, mild erythema, or irritation at the application site. Allergic contact dermatitis occurs rarely. Patients should avoid applying mupirocin simultaneously with other topical medication unless directed by the healthcare provider, because this may reduce drug effectiveness. The medication should not be applied to the eyes, mouth, or other mucous membrane. Routine laboratory monitoring is not necessary because mupirocin has negligible systemic absorption. Clinical monitoring should focus on improvement in lesion size, decrease erythema, reduce crusting, and complete healing within approximately 1 week. Patients should also be monitored for worsening infection, development of cellulitis, allergic reaction, or treatment failure, which may indicate resistant organism or the need for systemic antibiotics. Several evidence-based non-pharmacological interventions improve treatment outcomes and reduce disease transmission. Emily should gently wash affected area of skin with soap and warm water before each medication application. Removing crust allows better penetration of topical antibiotics. Frequent hand hygiene is essential. She should avoid scratching lesions, keep fingernails trimmed short, avoid sharing personal items such as towels and razors, cover drain lesions when possible, and wash beddings, towels, and clothes regularly until the infection resolves. These infection control measures reduce auto-inoculation and transmission to others. Emily should complete the full treatment course even if the lesions appear improved after several days. She should wash her hands before and after applying the medication and apply only a thin layer directly on the affected area. She should avoid contact with eyes and mouth. Clinical improvement is expected within 3 to 5 days. However, if the lesion continues spreading, fever develops, increased pain occurs, or no improvement is seen after 5 days, she should seek prompt medical evaluation. Unlike systemic antibiotics or sedating medication, topical mupirocin does not impair alertness or driving abilities.